Imagine holding your child and feeling a rush of affection, only for a vivid, unprompted image of harming them to flash through your mind, leaving you paralyzed with horror. Or a deeply religious person sitting in a place of worship who is suddenly struck by a loud, blasphemous thought that feels impossible to silence. This experience creates a psychological friction. These intrusive thoughts target the things people value most, acting as a direct inversion of the person's true character. While these dark flashes occur across the population, the distinction appears in the response. A brain caught in an OCD loop treats these passing signals as persistent data points, making the thought stick rather than allowing it to fade. The natural human instinct when faced with a terrifying thought is to fight it. You might try to push the image away, suppress the impulse, or immediately look for reasons why you would never act on it. But here is the central paradox. The struggle itself makes the thought louder. By fighting to prove you don't want the thought, you inadvertently keep it at the center of your attention. Your brain monitors the energy spent trying to force the idea away. It interprets that sustained focus as evidence that the thought represents a legitimate physical threat. Because the nervous system treats the internal thought as a mortal danger, the sufferer becomes trapped in mental warfare against their own mind. Pop culture often labels tidy desks or organized closets as OCD. This characterization omits the clinical core of the condition. In a clinical setting, OCD is defined as a doubt disorder. It is a malfunction in the brain's uncertainty mechanism, where the need for absolute proof becomes an obsession. This chart tracks the cycle. It begins with an intrusive thought that triggers a sharp spike in anxiety. To resolve that distress, the person performs a ritual or seeks reassurance. This causes a sudden, steep drop in the anxiety metric. This relief is brief, but acts as chemical reinforcement. It signals to the brain that the ritual was necessary, causing the next anxiety spike to register significantly higher. These rituals are the fuel for the disorder. They guarantee the next obsession will strike with more intensity, causing the feedback loop to feed on itself until the system overloads. Breaking this cycle requires a clinical intervention called exposure and response prevention, or ERP. ERP requires the patient to do the one thing they fear most: invite the thought in and refuse to perform the ritual that provides relief. This teaches the nervous system to tolerate uncertainty. Over time, the brain learns that the feared thought can be present without requiring a defensive reaction. Medication often serves as a support for this process. High doses of SSRIs act as an accelerant, making it easier for the patient to resist the urge to perform rituals during therapy. The most durable results occur when patients combine these medications with consistent weekly ERP sessions. The goal of treatment isn't to stop thoughts from occurring, but to disarm the brain's false alarm system so the thoughts lose their power to cause distress. Data shows that 70 to 80% of people who complete a full course of ERP see significant relief. For many, this relief manifests as a quieting of the mental noise that had been constant for years. Clinical help is recommended if intrusive thoughts consume more than an hour a day, if rituals interfere with your daily life, or if you are avoiding situations to prevent triggers. For those in Georgia, Coping and Healing Counseling offers telehealth sessions with ERP-trained therapists. They accept major providers including Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana, with session costs between $35 and $40 and a $0 copay for Medicaid. You can access a free 2-minute screening at chctherapy.com/mental-health tests or by calling 404-832-0102. Starting Care offers a path toward recalibrating the response mechanism and reclaiming the mental space these thoughts occupy.